AMD, this is, I think I told you guys last week, this is like the main thing I did for like 6 years of my life. I'd like to think I'm an expert at it, but I am rusty. I haven't seen a patient since October now, or September. We're gonna have a lot of fun with this. I'm gonna try to go fast because the best is at the end. So macular degeneration, this is an old term, and we're gonna talk about this in the lecture, and your book mentions it. Over half of the risk for AMD is genetic. There are some people that can't get it even if they have the worst lifestyle in the world, right? I heard once somebody said we should call this gene-related maculopathy. I like the word maculopathy better than macular degeneration. It's just fewer syllables. And degeneration makes it sound like, oh, it's just getting old. But there is also big age risk, right? So I propose a new name, and it's hereditary senile maculopathy. But I think a lot of my patients won't like the term senile. Nobody uses the word senile that much. It should just be the opposite of juvenile, although juvenile has its own connotation. So then I was saying, well, what's a less offensive term? So I thought maybe hereditary boomer maculopathy. So probably boomer's a little bit more offensive. So we'll just keep on calling it AMD. Maybe HSM will catch on someday in the future. I don't have any relevant financial disclosures because I'm unemployed. I am working at the DRCR, I guess, sort of a little bit. Anyway. So what is AMD? I was going to pose that question, but we really would need to march on. You guys have, okay, let me just ask one question. Military can pipe in too. And this is controversial. It's not a right or wrong answer. I mean, there's a few wrongs. There's a couple rights. Where does AMD start on a tissue level? Don't just say the eye. Sub-RPE, anybody else? I don't think, there's not a right answer. I have my own opinion, of course. Kelly, what do you think? Not the optic nerve. Blood vessels, endothelium, yeah, maybe. So it usually comes down to, and when I ask people, most people think it's either outer retina or RPE. I'm an RPE guy. I think it's the RPE, but who knows? Okay, leading cause of irreversible vision loss worldwide, if you're over 50. Most common cause of legal blindness in the US. I don't know if that's true, but the book says it. The book also says if you're over 65 in your developed country, you got a 10%. It's 10% prevalent. Amongst over 75, it's 25% prevalence. Lots of risk factors. I'm not going to read them all off. That was in the BCSC. Now, this is one you could check out. This is where I put fellows forum. If Ethan's still on the call, which he may not be, he probably had to go operate or something. I don't see him up there. This is more important for fellows. But basically, this study looked at the 5-year incidence of AMD. I think this is from Beaver Dam. I think this is also in Wisconsin. So if you looked at the greatest generation of people born, I forgot what years, basically greatest generation, then you have silent generation, baby boomers, Gen X. They said they adjusted for age. I don't know how you adjust for age when you have Generation X, basically barely in their 50s. So we'll say maybe Generation X doesn't count, but 9% in greatest versus 3% in silent versus 1% in baby boom. There may be a real decreasing incidence. And we don't know why that is. Maybe in the book they conjectured maybe it's the EPA law where we don't have leaded gasoline anymore. We know lead is a risk factor for AMD from some Korean studies. People have better dental hygiene. That does improve mental health in terms of dementia, and AMD does tend to kind of go along with the same cohort as dementia. We don't really understand it, but it may have a better forecast than we thought. They also, after adjusting for age and sex, found that the following had no associations with AMD. All the things that the BSC said there basically were associated. So who knows? They did find that these other two factors were predictive. Multivitamin use like AREDS was protective. Education level, protective. It's worth stating that risk factors could be different between the incidence, of AMD and the progression of AMD. Okay, aspirin use, we'll just say if your patient asks you about it, it might play a role. There are 3 big studies that say that it does. Officially, AAO, I think, says it does not. Just know it may double their risk for incident wet AMD. Okay, let's get back to the BCSC. So it says genetic factors account for at least 55% of the total variability in AMD risk, hence hereditary in the senile maculopathy. And 34 plus genetic loci. There's actually been over 52 that I saw in a paper a couple years ago. Complement system is often implicated. If you want to read more about this, it's a great paper, IRIS Consortium. I think they're based out of France, somewhere in Europe. 2 major susceptibility genes. This is all I think the BCSC wants you to know is CFH, ARMS2. If you have both of those homozygous, your risk is like 50-fold greater than the average person. Normal aging, I can't remember how many times I've learned about basal lamina or basal linear deposits. I always have to relearn it. Obviously, it's not clinically applicable, but it's supposedly part of normal aging. Rods more so than cones are reduced in density. So dry AMD, the defining lesion is the druse or plural drusen. It may or may not be accompanied by RPE hyperpigmentation or RPE atrophy. Dry AMD, the drusen, include those deposits, and it's important to know that drusen by themselves can cause problems. You can get atrophy, or you can get mild to moderate vision loss, decreased contrast sensitivity, decreased color vision, impairment of dark adaptation. Dark adaptation impairment is a common complaint when you sit and talk to AMD patients. We characterize drusen based on their size. Less than 63 microns, greater than 125 is large, less than 62 is small. And then you may remember when a vein exits the optic nerve, it's about 125 microns in diameter. So if you're really having to grade these things. Okay, and you can have a drusenoid PD if it's more than 350 microns of diameter. So here's more drusen, as if you guys didn't know what they look like, and then I highlighted. Here's some small ones, here's some intermediate ones, here's some kind of largish ones. And this is, okay, here's a drusenoid PED, almost a drusenoid PED, not quite big enough. I measured it, 341, supposed to be 350. Okay, RPE changes, you can get hyperpigmentation, get atrophy. We call it GA when it's greater than 175. I don't think you need to know those numbers. I've never been tested over, it's 150, is it GA or not? But when you're in research protocols, they'll often look at that. Often spares the fovea until later in the disease. The book says the rate of progression is almost 2 millimeters squared per year. There's a great paper. By the way, you guys should develop a way to keep up with the literature. I mean, it's important to go to meetings and stuff. Pick like 1, 2, or 3 journals and say to yourself, once you're done with residency, of course, I'm just going to look through the table of contents, or I'm going to flip through the whole thing and just read the things that are interesting or important. That's how most of the ones that are popping up here, it's not because I did a literature search for this presentation, it's because I have this little app and I keep track of what I read and what I don't read, mostly what I read. And if I see something that's interesting, then I'll take some notes on it. And then when I want to go back to it, I'll look at my app. But that's how I find these. And otherwise, you kind of get, you start to think that everything is the way it was when you finished residency or fellowship, whatever. And that's obviously not true. Okay. RPE changes. You can see the atrophy. Hyperreflectivity in that choroidal space is indicative of overlying RPE atrophy. I don't know if you guys knew that's a really great way if you're measuring RPE atrophy. So simplified severity scale, I've learned this. I don't use it that often. Every once in a while I'll have a patient say, what's my prognosis, doc? And I'll kind of get this out. So 1 or more large drusen, you get a point. This is from AREDS report 18. Any pigment abnormalities, 1 point per eye. If you don't have large drusen, but you have intermediate drusen in both eyes, you get 1 point. And then neovascular AMD in one eye is 2 points. And basically what they did was they assigned all these people 0 through 4 risk factors. They looked at their 5-year risk in AREDS and found their risk. This is the risk for developing advanced AMD. Does anybody know what advanced AMD is? It could be one of 2 things. GA or? Wet. Yep, you got it, or wet AMD. So if you're going to memorize something, just memorize the 5-year risk, and then it's almost double for the 10-year, except for that 50% column at the 4. So 0.5, then 3, then 12, 25, 50. Again, not super useful on a day-to-day basis. So hate to say that because they put a lot of time into it. So reticular pseudodrusen are important. I'm going to show you a picture of them in a moment. They're also called subretinal drusenoid deposits. They're smaller than soft drusen. They're on the apical surface of the RPE as opposed to below the RPE. And they're more heavily distributed in the superior macula, especially early. Sometimes it looks like they kind of migrate. They don't actually move, but over time they kind of see more inferiorly. The book says they're a risk factor for GA and CNV. I'm going to contradict that a little bit in a moment. But you could see here, here's the extent of them. You can see on the IR photo, which is probably the easiest way to see them, by the way, is IR. And then on the OCT, we sometimes call them witches' hats, STDs, so it's a good one to remember. And then you see more here. That's superior. So this is the paper, if you want to read it. This is from AREDS. Now we're up to report 30, AREDS 2 report 30. Emily Chu and some other authors. They're calling this like a third risk factor. So we talk about pigment drusen. You could say reticular pseudodrusen. They confer greater risk for GA than MNV. We'll get to MNV in a moment, or wet AMD. And they confer a greater risk to that low middle risk scores rather than the upper risk scores. Again, I don't want to stray from the BCSC too much. I'm on slide 30 of 108, so I got to keep going. Okay, differential diagnosis, central serous, pattern dystrophy, adult onset foveomacular vitelliform dystrophy, which is just rolls off the tongue, and drug toxicity, which includes the most important one I put in red because it's fairly new. It is in the book. The book has a chapter now that it didn't have a few years ago just on drug toxicity. It also has one on myopia, which is probably worth reading. I haven't gotten to it yet. Elmeron, raise your hand if you've heard of Elmeron. Okay, Elmeron is a drug that patients take for painful bladder issues, basically. And unfortunately, it puts them at risk for, I think it's that plus a genetic predisposition, but we haven't isolated the genetic predisposition because not everybody with Elmeron gets it. Think of it like in the same category as Plaquenil. It puts them at risk for it. They should get screened for it. Not many of them are getting sent over to be screened because they're largely prescribed by OBGYNs or urologists. I don't think I have a picture of it in here. Unfortunately, I should have put one in there. But it looks like it's a little bit of an unusual pattern of hyper and hypoautofluorescence, and we don't know if it actually predisposes to CNV or not, but I do have one patient that was getting treated for CNV that had Elmeron, and several lawyers had contacted her to push for her case to go forward. Anyway, good one to know. So how do we manage it? If vision loss is present, please send in the low vision, Amsler grid monitoring, or like a home OCT when that comes out. Lifestyle modifications we'll talk about in a moment, and then micronutrients. So smoking cessation, obesity reduction, blood pressure control. There's inconsistent evidence for cataract surgery and AMD link. There's weak evidence for UV exposure. We used to tell people to wear hats. I don't tell them that anymore. I mean, they should still wear a hat probably, especially if they're bald like me. And then there's no evidence between blue light exposure and risk for AMD, not yet anyway. I doubt there ever will be. That's my own soapbox though. So physical activity, this is, again, you don't have to know this, but physical activity is very protective, like 40% reduction odds ratio. That's for late AMD. Early AMD, it's not quite as beneficial, but it is still beneficial. Okay, so AREDS. Does anybody, I'm not going to ask. I normally would ask you what's in the AREDS supplements, vitamin C, E, what's up here right now, beta carotene. That's the old one, zinc oxide. So then we also heard that, okay, patients that are taking beta carotene in other studies were having a higher incidence of lung cancer in patients that formerly smoked or currently smoked. So then we're like, whoa, maybe we shouldn't be doing this. Before I get to that next slide, sorry, don't know what's coming next. So there are a lot of vitamins and supplements out there that people are taking. There's very few that have actually been studied. Well, this is one of the few that has been, in my opinion. So 25% reduction in risk for progression of advanced AMD at 5 years. If you're only going to remember one stat, that's the one to remember. And so what we did was we went and did AREDS 2. We took out the beta carotene. We put in lutein zeaxanthine and basically said, it looks like it's good enough. We tested out omega-3 fatty acids, found them not to be beneficial, but there is really good survey data. People that eat 2 or more fish meals per week versus those that eat 0, like top quartile versus bottom quartile, really big difference. Not really big, a modest difference. I think it was like 25% lower reduction or lower chance of AMD. What's that?
A couple of our co-residents are the anti-fish.
Oh, really? They're fish haters. Okay, we won't name names. Or maybe we will. So I started eating a lot more salmon after having this conversation like 30 times a week. So
It's all Brandon.
Yeah. So zinc was reanalyzed, and we tried to do 25 milligrams, but it wasn't quite as good as 80, so 80 stuck. Okay. All right, I really want to talk about GA treatments. Saving this for the end. If you guys have seen Tom Hanks in Black Jeopardy, he says, I got a lot to say about this after one of the slides, but we'll get to that. I've got a lot to say about these drugs. Dry AMD management, disproven therapies, macular laser. People are still doing it, by the way. I had a patient that was really upset that I wasn't going to continue his laser that was actually being done. Anyway, I can't give you too many details. I might tell you who it is. Not in San Antonio. Doesn't work. Maybe someday we'll find that. It makes the drusen go away beautifully, but there's no benefit that we know of. By the way, natural history, when drusen go away, photoreceptors usually die as well. So it's not necessarily a good thing to have drusen go away. Rheophoresis, I misspelled it, lampalizumab, and probably other things that will be disproven. I think it's important to know, I don't think I understood this until maybe after fellowship. It's probably obvious now to everybody. So intermediate AMD is inexorably it will inexorably progresses to GA. If you live long enough, it's going to go to GA. If it doesn't, then you probably have the wrong diagnosis. So if you have intermediate AMD, you will get GA. It's just a matter of how soon. Are there things you can do that slow that down? Yes. The things that I mentioned earlier that have been shown, like AREDS 2 probably actually does slow that down. There have been a couple studies just in the last couple of years that have finally seen that. Exercise probably makes a difference. Eating a Mediterranean diet makes a difference. Along that path, detours can happen. Like my little animation. Bleeding, right? This is where I decided to call this hereditary senile maculopathy plus. Make it really simple. Patients want to know, what's better, wet or dry? Do I have the better form? We've made it binary. It's not a binary disease. It's basically one disease, macular degeneration, with or without bleeding. It's like ketchup on your hamburger, no ketchup, right? Except you're not deciding whether you get ketchup or not. And ketchup, in this case, is a really bad thing, whereas normally it's a great thing. Especially spicy ketchup from Whataburger, right? So, but it is super important to understand, and I think we know that now. For a long time, patients will go, well, I had wet AMD, but now it's been cured, and now I went back to dry. Whatever. Okay, some people actually can wean off of drugs for their wet AMD, but that's a difference. That's beyond the scope of this lecture. It's dry macular degeneration. The terms are unfortunate. It shouldn't even be dry because we don't talk about things being both dry and wet. But when someone has wet macular degeneration, they still have dry. I think most people know that now. It's not that profound to say, but for a long time it wasn't. Okay, MNV, that's like the nom de jour. Or nom de guerre. So macular neovascularization. Does anybody know why we're using the term MNV instead of CNV now? We still use CNV. So MNV we changed because of wrapped lesions. I'll show you in a moment. It doesn't roll off the tongue like CNV, and we still have CNV. MNV is very specific to macular degeneration. It's really confusing. It's an unfortunate time to be in the nomenclature business for retina. Welcome. Abby, right?
Yeah.
Okay, we'll catch you up. Actually, I'm not pimping that much because I'm so far behind. All right, so signs. We could all name off a bunch of these signs. Fluid, this is for wet AMD. Exudate, blood, pigment ring, gray-green membrane, PED, RPE, tear, C-fan, pattern of subretinal vessels. So this is why we changed it from CNV to MNV. So the book spends a lot of time on type 1, type 2, type 3. Not very important in clinical practice. I hate to say it. In research studies, yes, it's still important because they like to cherry pick basically which patients are being enrolled in their studies. And a lot of them don't like type 3. So type 1, and it goes from deep to superficial, if you can remember that. It goes from bottom up. So type 1 is below the RPE. Type 2 is between the retina and the RPE. And type 3 is in the retina. And this is why we changed the names to MNV, because macula is more of a, loosey-goosey, it's just the region of the fundus that's posterior, right? So it could be in the retina or the choroid and still be part of the macula. So we called it macular neovascularization. In the old days, I would call those CNV. This is actually almost like a form of NVE, but we call it RAP. Okay. On fluorescein angiography, you probably need to know this to some degree. Classic CNV, bright, lacy, well-defined, early, and then later it leaks. And I'll show you one of these. Occult is a little bit harder. It's like a fibrovascular PED, is a stippled appearance. That's late leakage from undetermined source. I hate that term, but that's what we have. Fluorescence at the level of the RPE, poorly defined. We talk about the level of RPE. In the old days, you would get stereoscopic FAs. I've got these. If you ever want to see, I've got one book from like the 70s or 80s, and they have a bunch of little things that you put into the what are they called? The little viewing reels, what are they called? Something master. Anyway, and you see it in 3D. Have you guys ever seen those? Anyway, I'll bring it sometime. It's really cool. So when they say level of the RPE, it's because they can look in and go, oh, that's deep, that's in the RPE. It's really cool. And then type 3 CNV may produce a focal hotspot. So type 1 was the occult. Type 2 is classic CNV. These are literally their other names. And then type 3 is the RAP. So this is a patient, not going to pimp, 77-year-old male, 20/70 vision. What we're pointing at is, it doesn't seem that big of a deal, but we have some RPE depigmentation there. Anybody know what's different about that optic nerve or anything? I went through really fast the risk factors for AMD, but one of them was related to hyperopia. So this is a hyperopic disc, smallish disc, right? If you're myopic, you're maybe a little bit less likely to get AMD, but it still happens. This is the FA. So we see some kind of stippled. It's bright and early, bright, late. It's leaking a little bit. It's kind of meh, right? It's there. So we're going to say stippled, progressive, leakage. We're going to call it type 1. It's under the RPE. We see some PEDs over here. And now we've got another one. This is great. This is your gray-green membrane, right? And which one is that? That's classic CNV typically. So now we see, this is early. We still see some laminar venous phase on the FA, and then you see this almost well-demarcated lesion here, lacy, bright. And then as we go later, we will see that it leaks and it goes beyond, expands beyond those original borders. That's what leakage does. And this is a classic CNV. Okay, type 2 MNV. This is an OCT of one of my patients with CNV and a fellow eye. I just want to point out a few features here I was going to ask you guys about, but since I'm only halfway through, we got to press on. VMA is absent, vitreomacular adhesion absent. That's important because if you have vitreomacular adhesion, you may actually need to do, goodness, is it more shots or fewer shots? I think it's fewer shots. Well, I'll have a slide on that in a moment. Certainly there's a difference when they have a real PVD as opposed to a partial PVD. She has a rare ERM. She's got a PED here. By the way, a lot of people will say that little thing that's in orange is subretinal fluid. But if you trace the lines over that this is probably Brook membrane and this is RPE. Just go back to normal. This is RPE. That's ellipsoid zone. That's ELM. That IZ is really hard to see. Maybe say that's IZ. Maybe somewhere else is IZ. But that, if you trace it over, you'll almost never make the mistake up. Now, sometimes it's really hard to say. So like, what is this right here? So that's probably RPE that's elevated. Okay, and then you see where you see this bright light coming through? That's where RPE atrophy is. And then we see a couple of hyperreflective foci, which are a risk factor for CNV as well, or MNV. Okay, this is also a risk factor. We're not going to spend a lot of time on this because I don't think the book mentions it. Hyperreflective spaces, hyporeflective spaces within a drusen may be a risk factor as well. And that patient already had subretinal fluid and shrimp. Okay, PED, right? See the elevation and see this area right here that's a little bit kind of middle reflectivity. We should have a term for that. We don't have it. So we're going to hit that in a second. So subretinal fluid, CNVs, this is a vascularized PED, and shrimp. So what kind of MNV is this going to be if it's under the RPE? Type 1, 2, or 3?
Type 1.
Type 1, that's right. Don't know if that's relevant for anything except taking the test. Okay. This is called the onion sign, some crystals that show up in a PED. The book mentions it. I've never really looked for it. This is a double layer sign. This is a risk factor for progression to MNV. Okay, so when you see Brooks isolated from the RPE, you could just say this is like a PED, but some people like to call it double layer if it's sort of shallow PED. It increases your risk for progression, 21% 1-year risk versus a 4% risk. This is actually a patient, this is a little bit deceptive. This patient's already been getting shots and she was getting better. All right, so this is a 67-year-old female, 2025. She had metamorphopsia, just inferior to fixation. Looking at this, I don't see anything, right? So we got an OCT, except she has an MA up there. So we got an OCT, OCTA, and then we see this little area is a CNV. So then I move the little blue line to go right through it, and then if you look at the B scan here, it just looks like GA. I don't know why GA is showing up like projection artifact. I don't know why, but I'm going to say not CNV. But she was having a visual field deficit. OCTA is profoundly difficult to interpret objectively. So here's a different patient with CNV. See how it's kind of, and then I enhanced it a little bit, so now it's really obvious. And then 30 days after treatment, same area, you could see those vessels are less prominent, right? You can see why it's much easier just to go a structural OCT. The bottom images make it really obvious there's improvement. Here's an interesting one. You can see at the bottom it's 12 weeks. Oh, I should have improved the font here, but 12 weeks after the third shot, 16 weeks after the third shot, and 21 weeks after. So we're basically in an observation phase. And you could see that the vessels are slowly starting to come back. But then down below, she had some other vessels that were coming back, but she had no new exudation. In fact, she was getting better. So we just watched. I think it was a woman. I actually don't remember now. Okay, so the book talks about PCV. PCV is kind of a variant of AMD. This one is worth knowing. This is highly testable stuff. Multiple recurrent serosynchronous RPE detachments. I think I have that on another slide. It's a variant of type 1 because it's under the RPE. Originally described in African-American middle-aged women or Asian ancestry with high blood pressure, but now we see it in men and other ethnicities. In Asians, it might account for up to half of all the wet AMD cases. Caucasians, it's definitely a minority. I think about it a lot when you see VH. The other thing to think about when you see VH in an AMD patient is peripheral exudative hemorrhagic chorioretinopathy. They're more likely to get VH for some reason, probably because the retina's thinner. So again, multifocal can be peripheral, nodular orange. I have a picture coming up. VH is more common. They're more of a pachychoroid, thicker choroid. This is an update. Actually, the next point is, Everest studies showed the PDT plus ranibizumab, plus or minus ranibizumab, is superior to ranibizumab monotherapy, but then Planet came out and said aflibercept monotherapy was the same as aflibercept plus PDT. This used to be a Fellows Forum slide. Now it's part of the BCSC canon, so now you need to know it. All right, here's a patient with PCV. This is from Wilford Hall. Anybody know what I'm pointing at here with the orange arrow? Yep.
Fluid.
Yeah, that's right. Subretinal fluid. Here's a little orange subretinal lesion. There's some polyps. I should have pointed those out. Kind of superior temporal to the disc. Here, instead, I'm pointing out something that's not quite as important to know. Oh, and it's blocked. Basically, the image on our left is an FA. The one on the right is an ICGA. And there's a focal patch of RPE. Here, I'll go back. Nope, that didn't work. Focal patch of RPE and choriocapillaris atrophy, and it just highlights the difference between what FA and ICGA does. Remember, ICG stays in the vessels. It doesn't leak out like a sieve in the choroid. So on the right, ICGA, you see the actual choroid vessels from like Haller's layer or something. Whereas on the left with FA, that fluorescein leaks out everywhere, and it's like a sieve. It's just filling up that whole choroidal space. Oh, there, I did have it. See, didn't know my animation was coming. That's so. And then this is same patient on OCT. Okay. Management options. Laser, sometimes, if it's a peripapillary CNV, you better bet I'm going to think about it. May not be the best option, but I'm going to want to get them to that. I might start with anti-VEGF and then do a little laser towards the end, and then they won't need treatment for maybe 6 months, maybe 6 years. PDT was introduced, very rarely used now. Do you guys have PDT? Okay, yeah. We use it mostly for other diseases now. And anti-angiogenic therapies are the mainstay. Oh, good, I'm doing great on time. Still have my voice. All right, so the VEGF slap, this is what the properties of VEGF are. So it stops or prevents apoptosis in endothelial cells. It's protective for endothelial cells. It promotes lymphangiogenesis. We all know it promotes angiogenesis. And the original name of VEGF, as described by like Michael Singer in the 80s, was vascular permeability factor, VPF. The name got changed. But if you remember that was its old name, that gives you one of the other clues as to what it does. And think about in diabetics, we get leakage, makes sense. VEGF. There's more going on in diabetics and in AMD than just VEGF, but that's the main thing that we're treating at this point. It's actually a family. VEGF refers to a family of 5 different hormones, and so the first 4 are all VEGF A through D, and VEGF. And when we say VEGF, we usually just mean VEGF A, by the way, and then placental growth factor. It used to be PDGF or something like this. Something weird. Anyway, there's another one called pigment-derived growth factor. It's kind of confusing, but anyway, or PEDF. But placental growth factor is one of the VEGF molecules. That's important because when we talk about aflibercept's mechanism. So here we go. 2 slides on VEGF inhibitors. How many people know how many anti-VEGFs we can inject in the eye right now? Let's name them off. Avastin, Lucentis, Eylea, Vabysmo, Beovu. What else?
What's the old one?
Macugen.
Yeah.
And we've got ranibizumab biosimilar, BioViz, and Cimerli. So was that 8? I think I'm missing one. All right, we'll find out. Okay, so we got Macugen. Don't use it anymore. We've got stories on that, but don't have time. Avastin. It's a full-length monoclonal antibody, right? So whereas ranibizumab, the next one is an antibody fragment. It cut off the FC portion, so it will not go across the placenta. It will not get recirculated in your body. When you have an FC portion, your body goes, oh, we need to hold on to that. That's good stuff. And so bevacizumab and aflibercept both have FCs. They stick around longer. Does that translate into anything systemically? So far, we don't think so. But in babies, that's one of the reasons why some people advocate for Lucentis use in ROP over bevacizumab. But bevacizumab is still the most commonly used because it's cheap and it's worldwide available. Aflibercept, it's soluble decoy receptor. It blocks VEGF-A, VEGF-B, and placental growth factor. And that might be why it's better than ranibizumab. Who knows? Slide 2, brolucizumab, DBLL. So now, from now on, or from then on, 2019 on, or probably even earlier, all these biologics have to have this 4-letter thing now. And I don't know if they get to pick that or not. I think the company gets to pick that. Anyway, so it uses a complementarity determining region. Basically, it's a modified antibody fragment to bind VEGF-A. It has lots of problems. I don't know if I talk about it a whole lot, but nobody uses it anymore. It was very powerful. Faricimab is bispecific. The name Vabysmo has to do with the bispecific. That's how they like you to pronounce it. Binds Ang2 and VEGF-A. Probably should know that. We can't actually prove that the reason it's more powerful or lasts longer than other drugs is because of Ang2. It might just be because it's thick and syrupy and doesn't leave the eyes fast. I mean, who knows? It's all putative, right? Regeneron ran a study with Eylea versus Eylea plus its own Ang2 blocker, and that didn't make a difference. Maybe it's a different kind of Ang2 blocker. We just don't know. All right, aflibercept, 8 milligrams, Eylea HD. That's the one I was forgetting. Same thing as Eylea, just quadruple the dose. It's a slightly bigger volume. I think it's 0.07. It came out right as I was leaving practice. Haven't used it. Ranibizumab Nuna, BioViz, Ranibizumab EQRN similarly are also out there. Okay, trials. Goodness, there's so many trials. So we're going to say irrelevant on the Macugen trials. All you need to know of these bevacizumab trials is that they were non-inferior to Lucentis. They were basically all compared to Lucentis. CAT trials, super important. Lots of great data from that. I wish we had more time on it. Ranibizumab was Anchor and Marina. And aflibercept was View 1 and View 2. And the book didn't have anything on faricimab, so I kind of just skipped over because I've got other things to talk about. Quarterly treatment is suboptimal. We learned that from Excite and Peer. Yeah, somebody tried to basically base a new biosimilar approval, I'm not going to name any names, for a bevacizumab biosimilar off of Peer, like Q3 month treatment interval. That's just totally, that's unethical, and they didn't get approved. Horizon, most visual acuity gains were, basically Horizon was an extension study. They went to PRM, but they did not have very good treatment, retreatment criteria, so they didn't have good visual, they lost all the vision. CAT, the 5-year data, there's a lot to take away from CAT. So if you want to learn about CAT, this is not the slide for it. 5-year data showed that 50% of folks maintained 20/40 or better vision. Remember, that was ranibizumab versus bevacizumab, and it was like a 2x2, so they were either getting fixed monthly or PRN. And the PRN was fairly regimented, PRN treatment. And so when patients say, am I still going to be able to see in 5 years, you can quote, well, get a 50-50. You can say more than 50%, well, I'll say more than 50% chance that you'll have at least reading vision 5 years from now in that eye. Hopefully the other eye's doing better. But again, we have longer acting drugs, blah, blah, blah. So GA development or increase may be stimulated by VEGF-I. GA was worse than ranibizumab, kind of scared a lot of people. Now we're not as sure. Nobody talks about it. So Radical and Denali, we're looking at PDT stuff, and basically visual outcomes are inferior to VEGF-I monotherapy. That's why you don't hear about people sending all your patients out for PDT, because it's not commonly done. Fibrovascular PEDs may be at increased risk for RPE-RIB. Talk about that more maybe at a future date. VEGF-Is, we talked about this already, with an FC region have a longer systemic half-life. Hyaloid separation, that's like a full PVD, need fewer injections to achieve the same VA. I think I might have said that the opposite way. It's kind of weird. I don't memorize that one, because there's a different dynamic when you get a vitreous separation. The half-life of drugs does go down when you have a PVD, but you also have the other effect of you're no longer tugging on the macula, which also is making things worse. So it's kind of like, on balance, maybe it's better. Certainly, once you have vitrectomy, the half-life goes way down. Eyes with the arms do require more injections. If I can spell injections right, it's almost never too early to connect an AMD patient. Foot stomp, low vision, super important. Don't forget to talk about patients. Sometimes it's the most important thing we can do for them. Complications, we probably can all recite these by heart. Dry eyes, there was actually a really cool paper that said dry eyes improved with shots, looking at some Schirmer's test stuff. Anyway, if you want the paper, I can send it to you. It's not in BCSC yet. But certainly in the acute phase, dry eye is a lot worse. VEGF-I can potentially cause ocular hypertension. We're not sure. Some studies say yes, some say no. RD is a risk. I usually quote about 1 in 1,000 to 1 in 5,000. I haven't read a paper recently to update that number. Vitreous hemorrhage is possible. Endophthalmitis is somewhere between 1 in 1,000 to 1 in 5,000. Prefilled syringes, it might be lower. IOI is not talked about enough in the BCSC, certainly is a bigger concern. Obviously, there's a big issue with Beovu or brolucizumab. It's an issue with faricimab as well, not as obviously as much of an issue. There's a risk of MI, CVA, GI perforations with systemic administration of anti-VEGFs, but conflicting evidence as to whether it's really an issue for intravitreal anti-VEGFs in this population. Other causes of CNV, we'll fly through these: histo, angioid streaks, pathologic myopia, idiopathic. So histo, you guys probably know a lot about. Just think punched out lesions, no vitritis. On OCT, you may not be able to tell the difference. This is one of my patients with histo who requires frequent injections. You can see the lesions. And then angioid streaks. There's a whole differential on this. Pepsi, you guys may have, I think that's in the book somewhere. Pseudoxanthoma elasticum, Ehlers-Danlos Pages, sickle cell and idiopathic. Again, we talked about this last week. ABCC6, if you have somebody you suspect PXCN, get them genetically tested. Usually by the time you diagnose it, they've already had a heart attack or a peripheral bypass surgery or something like that. It's important to pick up. Also, they need to wear eye protection. Even mild blunt trauma can result in lots of hemorrhages. These don't need CNV or anti-CNV treatments like anti-VEGFs. They typically improve over time. They're just very unfortunate because they can leave subretinal fibrosis right through the fovea like this one did. Pathologic myopia, really unmet need here. We don't have a way to stop it. In kids, we give them atropine. Adults, we don't know if atropine helps. Nobody's studied it yet. I'd love for somebody to study that. Fortunately, they usually only need a few anti-VEGF injections. They don't typically need them monthly. And I will get OCTA a lot for these folks, and I depend a lot on their symptoms. Their OCT will look almost normal, like this one, and it actually does have a CNV, and I don't think I have an OCTA for that patient. Okay, we're going to get to it. Conditions associated with CNV, the book has all these listed. Hereditary senile maculopathy plus, pathologic myopia. You've got all these categories. It's important to spread the differential if it doesn't look like AMD. Okay, well, slightly less controversial than Lives That Matter is intravitreal injections for GA. And very similarly to Tom Hanks's character, I've got a lot to say about this, and I gave myself enough time. So, pegcetacoplan, Syfovre, and we also have another one called Izervay. Why am I blanking on its name? Anybody help? Avancicaptad Pegol. It doesn't really flow off the tongue either. So I don't have as much data on that. Derby and Oaks 2-year data. So this came out last year, and my first concern was the safety data. This is from the prescribing information. So we basically had 3 groups. Actually, we had 4 groups. We had a monthly group, we had an every other month group getting treatment, and the control groups were every month and every other month as well. And we had a lot of patients, like 600 in each of these studies. So we have I think, I might be missing it by a little bit, I think about 1,200 patients. So the monthly group had an incidence of wet AMD of 12%, okay? Every other month group is 7%, and the control group is 3%. So that's concerning, but not that concerning because we're like, well, we got anti-VEGFs. So you just get another treatment. Some of these patients in this study they weren't allowed to have wet AMD entering the study. But in clinical practice, if I have a wet AMD patient who also has GA, I have no problem giving them both, right? So we're like, okay, it's all right. Don't love it, but inflammation was higher in the monthly group, 4% versus 2% in the every other month group versus less than 1% in the control group. This wasn't hemorrhagic occlusive retinal vasculitis, asterisk, in the study. So it wasn't scary like brolucizumab, again, in the study. But still, a little bit of vitritis, a little bit of anterior uveitis, we can manage that. This one bothered me a lot. Ischemic optic neuropathy, and again, it's a small percentage, but it's basically 2% of the monthly group. This, for me, automatically ruled out doing it monthly. By the way, this is my own personal opinion. I'm obviously not employed by anybody, so I can say whatever I want. But there's going to be you may have some well-respected retina doctors here. I don't know any of your retina doctors' preferences. I mean, I knew what one of them was like 6 months ago. I don't know what it is now. And this is not intended to be disrespectful towards anyone. This is my own opinion. Happy to change it as facts change. So 0.2% on the ION or NAION, the every other month group, and 0% the control group. There were some post hoc analyses, looked like people that had disc at risk were more likely to get NAION. That's a no-brainer. But they didn't really look at like what percentage of patients across the board had disc at risk to begin with, so we really didn't know pretest probability that much. Death. Nobody wants to talk about this, but it's like 7% in the monthly group, which is basically double, almost double what the other 2 groups are. So again, I'm not going to do this monthly, but then if I have a patient every other month, should I tell them this is happening in the monthly? So I actually took a chart like this in a Word document along with like 12 Q&A things, and basically handed out to all my patients that were considering it. I said, listen, here are my concerns. It's been 5 or 10 minutes talking about it. Here's a handout. You don't have to remember anything I'm saying. Take this. There's no way I'm giving you this shot until you talk to your loved ones about this. I have some concerns. But this is just half of my concerns. The other half was this. So that primary endpoint, this is all not in the BCSC, by the way. Primary endpoint was rate of GA progression. Okay, and the two studies, well, actually one of them met it, Oaks met it, not Derby. You know why there's two studies?
For pharma approval.
FDA requires it. They want two parallel, randomized controlled trials, phase 3. So, and interestingly, one of them didn't even meet it. They had 4 secondary endpoints. Difference in reading speed. Actually, I didn't even list them all here. One was called the Functional Reading Index, something like that, FRI, maximum reading speed, best corrected visual acuity, and then a threshold microperimetry test. Do you know what a microperimetry test is? It's fine if you don't. Visual field testing is like a threshold perimetry. Microperimetry is basically like we project up a picture of the fundus, and then we also will say we want to test this point exactly. And so we'll shine a light where we think maybe there's RPE atrophy and say, do you see it, don't you see it? So think of it like regular Humphrey visual field, but now we could see exactly which part of the fovea is being tested. It has like an overlay of their fundus map. And we can get, they call it micro because we can pick these little tiny areas. So basically we looked at vision in normal illumination. The other group, the Gather studies for avancicaptad pegol, they actually had low luminance, best corrected visual acuity. But anyway, nobody met their functional endpoints, meaning vision, reading max speed, and then this threshold microperimetry. There was no difference whether you got the shot or didn't get the shot at the end of the 2 years. So I have a problem with that because when I tell a patient I'm going to give them something, I'm not expecting improvement. Everybody knows we're not going to improve anything, right? The only goal is to freeze it in time or to slow it down so it doesn't get worse. You're driving now, we want you to still be driving in 2 or 3 years. So we all get the concept. We're not improving anything, but we are trying to provide a benefit, right? We're trying to slow it down. That is a benefit. It's not improvement. So after 2 years, the sham groups were allowed to receive Syfovre. What does that mean? That means that we'll never have functional information on functional data for differences. We're not going to have 3-year data. We're not going to have 4-year data. In other words, my question to one of the reps, the hired guns that they send out, a retina doctor that came to speak to us in San Antonio, was like, so we know at 2 years there's no difference. There's no benefit. How many years do the patients have to be getting these shots every month before there actually is a benefit? Is it 3 years? Is it 20 years? Will they live long enough to actually achieve a quote-unquote benefit? So those are my problems, and I basically scared most of my patients away, which is totally fine with me. Then there's all this HORV data. Have you guys heard about that? So they've had several cases, I don't remember how many, of hemorrhagic occlusive retinal vasculitis or other variations of retinal vasculitis or occlusion, and not exactly like brolucizumab, certainly not as frequent. And in my mind, that was not a big game changer. I already quote to people, hey, if you get endophthalmitis, you could lose your eye. It's NLP. So that kind of in my mind, I put that in endophthalmitis. Now, the truth is endophthalmitis post-injections, it may not be that severe. I've certainly had NLP patients, but if you look at the data, most people get like reading or close to reading vision back if they were that way at baseline. But for some reason, those HORV cases scared a lot of retina doctors. But then this paper came out. And if you guys have not read Rick Spade, if you're interested in retina, Rick Spade writes some of the best papers. They've been the most, in my mind, influential. These are not randomized clinical trials. These are like his deep thinking about the retina. He's the one that basically is he's the reason why we call it the ellipsoid zone and not the ISOS. So because of a paper, because of diagramming. So he wrote this really interesting paper, and you could tell from this picture that it's going to be interesting. So basically, he's like, here's our simplistic interpretation of an FAF, fundus autofluorescence, which, by the way, we never got to that lecture. Someday we will do it. So we've got the happy RPE cell down below the optic nerve. He's got his arms up, he's lifting weights. That's kind of that normal fluorescence pattern, right? And then he's pointing for the other one into that inferior temporal area of the GA, and that's an RPE cell that's died and gone to heaven, right? And basically that we know because it's black, it's no longer there. So his thought is, well, so we know, here, I'll just read through it. This is straight from his paper. So if we look at the histology of RPE atrophy, in this area at the edge of it, we call it the junctional region, these RPE cells are sick. They're not working that well. And he says that they may even start to secrete abnormal hormones. We should go back to that in a moment. These cells, which are alive in the sense that they maintain metabolic processes and contain pigment and lipofuscin, and therefore are autofluorescent, but they're still not effective in their function. Okay? Next point, the immune system, of which the complement system is an important part, maintains retinal homeostasis by clearing these cells. So if we, hey Taylor, if we interrupt the complement system here, are we taking away our ability to clear out zombie or half-dead cells? And his hypothesis is that when we're disrupting complement, which is what I didn't even tell you, these two treatments are C3, C5 inhibitors, we might be just allowing zombie cells to stay there. So inhibiting the complement system, as he wrote, may reduce the ability to clear these cells, resulting in less loss of autofluorescence over time without functional benefits to the patient. In other words, the autofluorescence would look better, but it wouldn't necessarily be functionally better. And again, these two drugs their approval is predicated on the idea that FAF, or that these zones of RPE atrophy not getting larger as fast was someday going to be meaningful. But what if we're actually just leaving half-dead cells there that do nothing? These cells also, we do know that RPE cells secrete VEGF, and it might be that the sicker they are, the more VEGF they secrete, and that might explain why we have a higher rate of macular neovascularization in these patients getting these shots. 12%, like quadruple. So that's what I'm going to leave you with. If you have an attending that loves doing these shots, I would just say ask him or her about it and what their thought process is on it. I doubt you do have somebody who loves these shots. I personally think, well, here's my one question I'm going to leave you with, and this tells you what I think. Are Syfovre and Izervay the emperor's new clothes? So I think because of the HORV cases, all the retina doctors for the most part have pulled back from doing these shots. But prior to that, they were being used quite a bit. I was obviously using the trepidation. I'm not saying this in a self-congratulatory way. We need a treatment for this disease. It's a very bad disease. I have a lot of patients that are desperate. It's a very sad conversation to have with somebody when they think that their wet AMD is being treated perfectly well, but then they're still losing vision, and that's inevitably what happens. So sorry to leave you on a downer, but I think it's important to ask these questions, to think about these things while you're still young and are impressionable and are still, as you get older, you kind of stop sometimes thinking deeply about things. Rick Spade is the exception to that rule. So thanks for your attention. HSM Plus, and here's my references. I think that's it. Any questions? I finished on time for once.
Thank you so much, Dr. Bass. That was great.
Yeah, you bet. My pleasure.